Hello, everyone. I'm Travis. I'm a second year, about to be third year resident, surgery resident here at Northside Medical Center. Um, this lecture is about small bowel and hernias, and this is kind of geared more toward the shelf exam, not necessarily. You guys need to know the surgical steps of repairing a hernia, although it is helpful for the surgery rotation. But this is geared more for your shelf exam. So we'll just start with some basic anatomy. The small bowel starts after the pylorus of the stomach, becomes the duodenum. The duodenum then transitions into the jejunum and then the ileum, which will then transition into the colon. So the duodenum is the first portion. It's made up of 4 different parts, which we'll go over in just a second. The jejunum is the longest part, and then the ileum is the third portion of the small bowel. So the duodenum, this is located at the level L1 to L3. It begins at the duodenal bulb, just past the pylorus after the stomach, and then it ends at the ligament of Treitz. It has 4 parts. The first part is intraperitoneal. 90% of the ulcers occur here, obviously, because it's right at the junction of the pylorus and the stomach. The second portion of the duodenum is a very important part of the duodenum. It's descending, it's retroperitoneal, but it also receives pancreatic enzymes from the pancreas and then also bile from the biliary system that drains through the ampulla of Vater. The third portion of the duodenum is transverse, and it again is retroperitoneal, and then it protrudes out through the retroperitoneum to the fourth part, which kind of ascends before it transitions into the jejunum. So it's C-shaped. The duodenum is C-shaped. You'll hear that. Next is the jejunum. It's about 100 centimeters. This is where all the absorption occurs except for B12 and the bile acids and iron. The iron is actually absorbed in the duodenum. Bile acids and B12, and we'll talk about right now, is absorbed in the ileum, which the ileum then is the last portion of the small bowel before the colon begins. So small bowels were essentially almost all the nutrients are absorbed, mainly because of the surface area of the microvilli on the mucosa. The small bowel is made of 4 different layers: the mucosa, the submucosa, which is where the lymphatics and the blood vessels supply the wall of the small intestine. Then you have the muscularis layer, then the serosa layer. So the blood supply to the small bowel is very rich. That is due mainly because of absorption, of all the nutrients. So the blood supply has to be expansive. So with the exception of the proximal duodenum, which is supplied by the celiac trunk, specifically the superior pancreaticoduodenal and inferior pancreaticoduodenal arteries, the small intestine is supplied by the SMA, the superior mesenteric artery. As you can see in this picture, you have multiple major arteries off the SMA, like the ileocolic and the ileal, which will break off into long vascular vasa recta, which will then split again into like vascular arcades, which is kind of hard to describe unless you're intra-op looking at the mesentery, but you can actually see these vascular arcades to the small bowel. It's pretty impressive. So the endocrine function, this is something that step 2 they'll love testing on, even in the shelf as well, the different types of GI hormones. So we'll just talk about a couple here. The most, I think, you have gastrin, which is secreted from the duodenal G cells. I'm sorry, that's actually that's a typo. I think this is supposed to be G cells in the stomach, actually, in the antrum. This actually stimulates gastric acid secretion, and then the analog is used to measure maximal gastric acid secretion. So if you think about Zollinger-Ellison syndrome, this is when you have hypergastrinemia. You have a patient that presents with multiple ulcers throughout the stomach, throughout the distal small intestine, which is rare. This is kind of a unrelenting gastrin secreting tumor, so these patients usually require surgery. Again, this is the antral G cells in the stomach, not the duodenal G cells. CCK, cholecystokinin, is secreted by the duodenal I cells. These enzymes are responsible for pancreatic enzyme secretion, gallbladder contraction, and then subsequent relaxation of the sphincter of Oddi. And this inhibits gastric emptying. So if you think about the food coming from the stomach into the small intestine, stimulates the eye cells to secrete the CCK. So it's going to tell the gallbladder, hey, you have food. We need to digest this. So the gallbladder contracts, but the sphincter Oddi has to relax so the bile can get into the small intestine. So it's kind of a coordinated effort by the CCK. And the third, and certainly not the last GI hormone, is secretin. It's secreted by the S cells of the duodenum. This is important for bicarb secretion, kind of counteract the acid coming from the stomach. And there's a secretin stimulation test, which is a common question to diagnose gastrinoma. So next, this is probably one of the most common general surgery consults that we get. It's called small bowel obstruction. So there's multiple different types of small bowel obstruction. There's partial and there's complete. Partial, usually the patient is passing gas. Maybe they haven't had a bowel movement for a couple of days, but they're at least telling you that they're passing gas. A complete obstruction is when a patient's not having bowel movements and they don't remember the last time they passed gas. So this is very common. We get tested on this all the time, and this is something we talk about a lot during your surgery rotation. So you should be aware with how to, one, diagnose with history and physical, radiological findings, and then how you treat these patients. So the most common cause of small bowel obstruction, first off, is adhesions. So any intra-abdominal adhesions caused by abdominal surgery is the most common cause of small bowel obstruction. Anytime the abdomen is entered during surgery, always a chance of forming scar tissue or adhesions in the abdomen, and then the small bowel will kind of kink around it, or can be encountered with abdominal surgery, but mostly with pelvic surgeries, like hysterectomies, are known to cause dense adhesions, especially in the pelvis. Another common cause of small bowel obstruction in someone that's never had abdominal surgery before is a hernia. So again, this is why history and physical is so important. If you're able to localize any type of abdominal scars from previous surgeries, either little laparoscopic scars or large open abdominal surgical scars, those are very pertinent to your history and physical exam and kind of formulating your differential diagnosis for small bowel obstruction. It's also important to palpate for any type of hernias. If they have a little umbilical hernia or a ventral hernia that's not reducible or incarcerated or strangulated, obviously it could be the major lead point of the small bowel obstruction. But you could also want to palpate for any type of reducible inguinal hernia or femoral hernia, especially in little old ladies. These can be causes of small bowel obstruction as well. Other causes not as common, you have a carcinoma or tumor, abscess, stricture, especially in Crohn's patients that are prone to forming strictures, and then gallstone ileus, which I talked about in my gallbladder lecture. So clinical signs, obviously history is an important part. They're going to complain of crampy abdominal pain, nausea, vomiting, obstipation, which is unable to pass any type of stool or gas. The patient they will sometimes subjectively say that their abdomen is bloated and distended. So that's something you should be able to find on physical exam. They're distended, they have hyperactive, kind of high-pitched bowel sounds. They're tender, they're tympanic. These abdominal exams are very important. On labs, they might have a little bit of a white count, lactic acid elevation. So why do you think they would have a lactic acid elevation? So typically these patients with small bowel obstruction are usually very severely dehydrated. Their appetite's poor. They often have nausea and vomiting. They're not taking much fluids, and the obstruction is kind of causing a malabsorptive state. So you're turning your metabolism into anaerobic metabolism, which increases your lactate. So these patients need to be aggressively resuscitated, and they're often severely dehydrated. So severe obstruction, at its worst, can cause ischemia, necrosis of the small bowel, which would need surgical intervention. So on imaging, diagnosing someone with small bowel obstruction, an upright abdominal X-ray, or we call it an acute abdomen series, is a good place to start to diagnose small bowel obstruction. You'll have dilated loops of small bowel proximally with decompressed bowel distally. You may have air fluid levels as well. If you look on this X-ray here, um, in order to differentiate between small bowel and colon, you can see these plicae circularis, which is circumference. So management, again, we talked about these patients being severely dehydrated with lack of PO intake. They often have nausea and vomiting. Their urine output isn't great. So these patients need to be aggressively resuscitated. So you don't want to, they're obstructed from something, so you do not want to put anything into their mouth, obviously. So you want to give them bowel rest, so nothing by mouth. IV fluid resuscitation, you want to correct any type of electrolytes that may be off. And most of the time, these patients are going to need nasogastric tube decompression because the contents in the small bowel and the stomach are backed up and they're at risk for vomiting and aspiration. So an NG tube will help decompress all of this, and a lot of times patients will feel a lot better once they get decompressed by this NG tube. Placing an NG tube, I don't know if any student has been a part of that, or it's about one of the worst things you can do to an awake human being. So I don't wish it upon anybody, but it does help. So indications for surgery for someone with small bowel obstruction. So typically we like to conservatively manage these patients for 2 to 3 days. If they don't open up, which means they're still not passing gas, they're not having bowel movements, they're still having persistent nausea and vomiting, their abdominal exam remains distended and tympanic and non-resolving, these patients often require operative exploration. And obviously, if they become peritoneal, which is indicative of some type of peritoneal inflammation, which can mean some type of rupture or ischemic event in the bowel, or fever, increasing white count, free air, obviously that's a peritoneal sign, and pneumoperitoneum. These are all indications for operation. So on the operative part, you guys don't get tested on this, but I think it's good to know just from surgical rotation. Going in, you'll run the small bowel from the ligament of Treitz, which we talked about, which is the distal part of the duodenum, all the way to the ileocecal valve, which is the end of the small bowel. So you'll run the whole length, and you'll usually find the proximally dilated part. And hopefully, if you work your way down to the ileocecal valve, you'll find the transition point. Either it's at adhesion, or the bowel is kinked on itself, or it's in a hernia. And as long as the bowel looks viable and healthy, you can just kind of get rid of the adhesions and kind of close up. Or if it's hernia and the bowel is dusky and not viable, then the bowel obviously should be resected. So ileus, I guess this is a tough concept for me to understand as a med student, differentiate between ileus and small bowel obstruction. Small bowel obstruction is a mechanical obstruction, either caused by adhesions or a hernia or a mass or a tumor or abscess. Well, an ileus is more of like a physiologic obstruction. It's not a true obstruction, it's just the bowels are not kind of contracting and working normally, which can cause kind of a generalized dilation of the small bowel. So, like it's listed here, an ileus is kind of a loss of peristalsis without obstruction. Risk factors, so recent abdominal surgery. Anytime you have a big abdominal surgery, you close up, and with manipulation of the bowel, it takes 24, 48, maybe 72 hours for the bowel to return to normal function. Patients that are immobile, any medications that slow the GI motility can cause an ileus as well. So in the history, they'll usually complain of diffuse, constant abdominal pain, nausea, vomiting, no bowel movements. Um, on imaging, you'll have distended loops of small bowel, but you'll also have kind of large bowel as well, and you'll have air in the rectum. So that's kind of indicative that air is moving through slowly, but it's everything's still kind of backed up from a generalized ileus. So treatment is kind of similar. You bowel rest, NG tube, IV fluids, you correct electrolytes, because that can be a major cause of an ileus as well, especially abnormalities in potassium and magnesium. And then discontinue any type of offending agent if someone's on narcotics or someone's been immobile. You got to get them up out of bed and moving. Gallstone ileus, I talked about this in my gallbladder lecture, so I would refer back to that. Again, this is a large stone that's eroded through the gallbladder and formed a fistula with the small bowel. Usually what happens is the gallstone will get lodged in the ileocecal valve, and then it will cause a mechanical obstruction, which that's why gallstone ileus is kind of a misnomer, because it's not really an ileus, it actually is a true obstruction. So the treatment for this, which I didn't really talk about in my gallbladder lecture, so you don't have to know this for your test, but from a surgical standpoint, it's pretty interesting to note that at the site where the stone gets lodged in the ileocecal valve, usually these are large stones, and it compresses against the small bowel. So this area of small bowel can be compressed and kind of devascularized. So you don't want to remove the stone there. You'll actually milk the stone proximally back into the small bowel further, and you'll open up the small bowel there and then take the stone out and then close the bowel. Because that's not really healthy bowel where the stone was lodged. So that piece of bowel actually may have to be resected. But that's kind of the surgical principle behind it. Next, we'll talk about carcinoid syndrome. They love this syndrome just because it's kind of confusing and it presents in mysterious ways. So symptoms usually arise if there's metastasis of the carcinoid tumors. So all of the kind of the biological hormones secreted by carcinoid syndrome are broken down in the liver. So anything proximal to the liver that gets drained via the portal system, if they have carcinoid tumor, you may not manifest the carcinoid symptoms because all of the hormones that are secreted are digested and broken down in the liver. So in order to kind of exhibit the carcinoid syndrome signs, the tumor usually has to be metastatic to the liver, that's overwhelming the liver, or has to be distal to the portal venous system where it gets to the heart. And then you'll start exhibiting the carcinoid-like syndrome, which is the cutaneous flushing, the diarrhea, the cramps, wheezing, and like I said, the right-sided valve lesions, because it's usually affects the right side. So the most common location for carcinoid syndrome, for carcinoid tumors arises in the, I think it's the appendix and then also the ileum. And like I said before, metastasis to the liver and beyond produces symptoms. So diagnosis, this is something that they love to ask. It's urine levels of 5-HAA, or I think they like it. Now they like more of the metanephrines. They like I think it's the urine metanephrines. So treatment is kind of symptomatic. You treat with octreotide. If you guys know what octreotide is, it's a somatostatin analog. And somatostatin, I think of it as kind of like the ultimate negator. It prevents secretion of a lot of different hormones. So this is kind of, octreotide will kind of prevent the release of this 5-HAA chemicals. And then you want to essentially surgically resect it, especially if these patients are having symptoms. But a lot of times, these carcinoid tumors will be found incidentally during appendectomies. So the surgical approach is a little bit different depending on the size of the carcinoid tumor and then where it occurs. So a carcinoid tumor that's located at the tip of the appendix, as long as it's less than 2 centimeters, you don't need to do any further resection. An appendectomy is sufficient. If there's a carcinoid tumor that's located at the base, next to the cecum of the appendix, then this patient's going to require a right hemicolectomy. You have to take out that right colon because there's a risk of metastasis and kind of local spread to the colon. So a patient that comes in with acute appendicitis and it comes back carcinoid tumor at the base of the appendix, this patient has a drastic change in surgical approach down the line. They'll need part of their colon taken out. Next, we'll talk about mesenteric ischemia. This is insufficient blood supply to the small intestine due to occlusion of the SMA. So the SMA is the major blood supply to the small intestine, and as you know, ischemia of the mesenteric vessels. This is caused in a chronic fashion, or this can be in an acute fashion. So acutely, which is the most common cause, and it comes from some type of embolism, which most likely comes from the heart. So someone that is an AFib, or they have endocarditis, or they had a recent, MI. These, you need to be on high alert for these symptoms. If someone comes in with acute abdominal pain, and you look at the monitor and their heart rate's irregular at 110, they're an AFib, they may have thrown a clot. A chronic cause of mesenteric ischemia, SMA thrombosis. This occurs just like any other, arterial supply of the body. You have atherosclerosis. You have chronic occlusion and thrombosis of the SMA artery, which will eventually occlude, causing acute ischemia. So again, just like for CS and CK, history and physical is very important. So these patients usually present with severe abdominal pain out of proportion to the exam. So you'll touch on their belly and it's soft and it doesn't have peritoneal signs like rigidity or guarding, but they want to jump off the bed. And you look at it like, wow, that's out of proportion to what it feels like. So these patients may also exhibit nausea, vomiting, and they may have bloody stools as well. So what's concerning about bloody stools is that the ischemia is now transmural and causing some necrosis of the bowel, which would present like bloody stools. Again, another important history part, these patients often have abdominal pain after eating plus weight loss. So we call it food fear or mesenteric angina, where when you eat, obviously the blood supply is kind of redirected to the bowel for absorption, but in this patient, the blood supply is compromised because of a thrombosis. And this is over many years issue. So these patients will often have like a 30 or 40 pound weight loss over a couple months. They don't have an appetite, they're afraid to eat. This should, raise a red flag to you, saying that, hey, this patient may have chronic mesenteric ischemia. So for diagnosis, you can do a CAT scan. It'll show bowel wall thickening, which is suggestive of ischemia and edema. But the best test is a CT angiogram, which will it's with IV contrast. Like the contrast will go through the vessels and it'll highlight, whether there's an occlusion at the SMA. It also allows for intervention as well. If you can anticoagulate. You can put a stent, or you can inject a thrombolytic as well. So treatment for acute mesenteric ischemia, which I just kind of talked about. First step is volume resuscitation, antibiotics. So volume, these patients there's ischemia. Obviously, it's a volume deficit. There's occlusion, so you want to try to give them as much volume as possible. And you can prophylactically give them antibiotics, especially if it's bowel wall edema suggestive on CAT scan. There may be some bacterial translocation into the vessels, and you want to prevent from severe infection. So the surgical treatment for an acute embolus is an embolectomy. You'll literally open up the SMA vessel and you'll put catheters down and you'll try to scoop out any type of clots that may have been thrown from the heart. You also want to assess the bowel. You want to take out any bowel that is gangrenous, and you'll want to anticoagulate these patients. So for chronic mesenteric ischemia, again, you want to resuscitate them first, but the surgical approach is a little bit different. It's not from an acute embolus, so this is more of an atherosclerotic chronic process where you can do an endarterectomy, which as a med student I was like, oh, I don't know what the hell that is. So what you basically do is you kind of open up and fillet open the SMA artery, and then you can, very carefully remove the calcified atherosclerotic portion of the artery. It actually comes out intact. Then you can close up the artery, and then your blood flow is essentially restored. But if it's if it's occluded, then you may have to bypass it, or you could stent it, which is angioplasty. So Meckel's, I know you've heard this before. It's the most common congenital anomaly of the small intestine. It's a result from the failure of closure of the vitelline duct. I think that's one of the buzzwords they like to ask about in questions. So it's failure of closure of the omphallomesenteric duct too. That's another word for it. So just remember the rule of twos. It's a true diverticulum because all three layers are involved with the small bowel. And there's usually two types of tissue within the Meckel's diverticulum. There's gastric mucosa and pancreatic tissue. So these are also the number one cause of GI bleed in kids because the gastric mucosa secretes gastric acid, and then on the opposite wall of the diverticulum, that acid will kind of erode into the wall, causing bleeding. So that's a kind of the physiology of why these kids get GI bleeds. Most cases are asymptomatic, it's just kind of an incidental finding. Like I just said, it's the most common complication is GI bleed. Small bowel obstruction is the most common presentation in adults. It can cause a volvulus or an intussusception, which I know you guys heard of the red Curran jelly stools. So diagnosis of a Meckel's is a protectinate scan or a Meckel scan. They love asking that question on how to diagnose it. And then you can also use barium studies as well. Treatment, usually you want to surgically intervene just with a diverticulectomy. You usually remove a portion of the ileum with it as well. If they're asymptomatic, it's not removed unless there's gastric mucosa present. It can be removed electively. Next, we'll move on to hernias. So I don't know if you guys know like the true definition of a hernia. So a hernia is a protrusion of bowel through any point of the anterior abdominal wall. So you have multiple layers of the anterior abdominal wall that kind of keeps all of the intra-abdominal organs, kind of in its place. But if you have a weak spot and you have increased intra-abdominal pressure, you may have a little piece of bowel that protrudes through where it's not supposed to, and this is what presents as a hernia. So if you look at the diagram here, we've just a couple of examples of an epigastric hernia or a ventral hernia. You have an umbilical hernia, you have a Spigelian hernia, incisional, and then inguinal and femoral hernias. So inguinal hernias, this is by far the most common type of hernia. You have three different types. You have indirect, direct, and femoral. We'll talk about kind of the anatomy, why these are categorized as they are. There's a higher incidence in men than women. However, indirect inguinal hernias are the most common hernia in men and women. And the risk factors, just kind of think about, increased intra-abdominal pressure, age, just because of their musculature gets weaker, obesity, heavy lifting, COPD, just because they're chronically coughing, chronic constipation, and pregnancy. So all of those, just think about the increased intra-abdominal pressure and how it would weaken kind of the anterior abdominal wall over time. So the inguinal anatomy, so you have the inguinal ligament, which extends from the anterior superior iliac spine to the pubic tubercle. Then you have the inguinal canal, which has a deep and superficial ring, which is important intraoperatively. And then the inguinal canal contains the spermatic cord and the round ligament for women. So the boundaries, I don't think you guys really have to know this, just kind of take a look at it and kind of familiarize with it yourself with the anatomy. To be honest, this is one of the most anatomically challenging cases for a resident and for me in particular. Just kind of identifying what's what, and an inguinal hernia repair is very difficult and not as easy as it appears in the diagrams. So direct inguinal hernia. So for direct and indirect, you have to kind of keep yourself in line with the inferior epigastric vessels. So categorization of an indirect versus direct is dependent on where they are in relation to the inferior epigastric vessels. So direct inguinal hernia protrudes medially to the inferior epigastric artery. And they usually protrude through Hasselbalch's triangle, which the boundaries are spelled out here on the slide. This is more medial, and it occurs in this triangle, and that's the difference between a direct and indirect hernia. So indirect, these occur lateral to the inferior epigastric vessels, and this is due to a persistent processus vaginalis. Again, that's another kind of buzzword. So Meckel's diverticulum is persistent vitelline duct, and indirect hernia is due to a persistent processus vaginalis. This is the most common hernia in children, in males, and in females. So just keep that in mind. Next, we'll talk about femoral hernias. These are more common in females, especially little old ladies. But again, this isn't the most common hernia overall in females. So femoral hernias, they pass through the femoral canal, which if you guys, again, this is a tough anatomy lesson. It's medial to the femoral vein, but lateral to the lymphatics, and posterior and inferior to the inguinal ligament. So this is right into the femoral canal. So class presentation for these patients is a bulge on the anterior medial thigh below the inguinal ligament. These patients usually present with also small bowel obstruction and obstipation or chronic constipation. Their bellies may be distended and bloated and tympanic. These are all kind of, red flags to you saying, hey, this patient is probably some type of small bowel obstruction from a hernia. And you have to have a high clinical index of suspicion for a hernia, especially in little old ladies, just because of the high risk of incarceration and possible strangulation of the bowel. So management of hernias in general, you kind of have to elucidate in their history and physical whether or not it's symptomatic and painful, if it's reducible, do they have any signs and symptoms of bowel ischemia or gangrene? Are there any skin changes over the region? Again, this is all kind of leading you toward bowel viability. So if someone comes in with acute abdominal pain and you notice kind of a dark purplish lump in their umbilical region, and they say they haven't had a bowel movement or passed gas in several days, they have severe abdominal pain associated with fevers and chills, you in your mind, you have to be thinking based history and physical exam, the likelihood of them having a strangulated hernia is very high at this point, causing small bowel obstruction, and this needs to be surgically explored. Another thing that's kind of tough for medical students to kind of differentiate is this difference between incarcerated and strangulated hernias. So if you think about what a hernia is, you have a protrusion of bowel through a weak point in the abdominal wall. So when the bowel protrudes through the abdominal wall, it then is called a neck. So the neck can be wide, which means that the bowel can kind of come and go as it pleases. But if the neck is narrow, the bowel can protrude out from the abdominal cavity and then get stuck because the neck is narrow. So these are tough because these hernias are very difficult to reduce. And the other dangerous part about this is that the longer the bowel is incarcerated, the blood flow starts to become compromised. So venous return is decreased, causing reduction in arterial inflow and edema and swelling, and the viability of the bowel is becoming compromised. So prompt recognition and hopefully reduction of these hernias is very key. So incarcerated hernias is when the bowel is stuck and you can't reduce it. But this can progress to a strangulated hernia, which means you are starting to have ischemia and necrosis of the hernia contents, and that may be bowel or that may be fat. But That's the progression of an incarceration to strangulation, is when you have ischemic changes. So asymptomatic hernias, they do not have to be fixed. You can have it done as an outpatient electively if it's causing disfiguration or the patient wants to have it done. But if it's asymptomatic, not causing any issues with their bowel or urinary habits, there's no surgical indication to fix it. But if they are symptomatic, but it is reducible, it's still an indication for surgery. And then obviously if these patients have an incarcerated strangling hernia, this transitions to more of an urgent or even an emergent type of surgical case. So other hernias that you'll encounter, whether you're an internal medicine doc or family doc or even a pediatrician, being able to recognize these on physical exam to get the appropriate referral to a surgeon is key. So umbilical hernias, these can be congenital or acquired. They usually close spontaneously by age 2. You don't have to fix them unless they're beyond age 5, because most of them will resolve on their own, and there's a risk of incarceration in adults. An incisional hernia, just kind of what it sounds like. This is usually a patient that's had a previous operation. They've had an incision in their skin. You'll see a scar and a weak point in their fascia where either it's broken down or the increased intra-abdominal pressure kind of overcame the strength layer, and some type of abdominal content protruded through it. So again, the risk factors are about the same: obesity, advanced age, malnutrition, where their protein levels, albumin levels are low and they can't heal and form a good strength layer, COPD because of chronic coughing, and if the patient's had a previous surgical site infection, that can weaken that area as well. A peristomal hernia, I won't spend too much time on this. Patients who've had an ostomy before, obviously you create a defect in the anterior abdominal wall, and then over time, sometimes pieces of bowel can sneak through that defect and could be cause of peristomal hernia. A Spigelian hernia, this is more just kind of a interesting name and kind of mechanism, but this is when a piece of bowel protrudes through the semilunaris line, which is lateral to the rectus muscle, and this usually occurs below the arcuate line, which the arcuate line is where the posterior rectus sheath runs posterior, but then below the line is when the posterior rectus sheath then goes anterior to the rectus muscles. So it's kind of an inherent weak spot in that lateral portion of the abdominal wall. So that's a Spigelian hernia. These most often have to be operatively fixed because of a high risk of incarceration. So next, I think we just have a series of questions, and that'll be it for the small bowel and hernias. So first, 60-year-old female presents with diffuse abdominal pain and vomiting. She's not had a bowel movement in 3 days. Physical exam results hyperactive bowel sounds, tenderness, no rebound or guarding. X-ray reveals distended loops of small bowel and no gas in the rectum. Which of the following is the best initial step in management of this patient? So again, this is what we kind of went over. This is why a history and physical is so important. No bowel movements, hyperactive bowel sounds, tenderness, but no peritoneal signs. X-ray reveals distended loops of small bowel and no gas in the rectum. So, and what I do for these questions, I like to get at least a differential diagnosis of what's going on here. So in my mind, she has some type of small bowel obstruction. There's no gas in the rectum. She hasn't passed gas, no bowel movements. So again, this is what CK likes to do. They like to ask, what do you want to do first? So the best initial step in the management of this patient is what? You going to take them to emergent surgery? No, we're not doing that. Are we going to put them on a diet and let them have surgery in a week? No, these patients are obstructed. We can't put anything more into their system. You can just give them morphine for pain and so forth. No, that's not either. So you got to resuscitate these patients. These patients are dehydrated. Their electrolytes are off. They need decompressed with an NG tube, and they have nothing by mouth. So correct answer is B. Question 2. I'm not going to read these anymore. I'll let you guys read them, and then I'll just discuss them. All right, so what do you think this question is describing? 6-year-old boy with a bloody bowel movement. Is that normal? No. Most common cause of a GI bleed in a kid is a Meckel's. So this is confirmed actually because this is an easy question. It gave you the protecting the Meckel scan. It's saying it's positive, just proximal to the ileocecal valve. So again, this is some type of Meckel's diverticulum causing a bleed in the ileum. So I talked about this earlier. Why do Meckel's diverticula bleed? So Meckel's typically has two types of tissue inside of it. It has pancreatic tissue and gastric tissue, which are the most common. So if you think about gastric tissue, which is what? It has acid-producing cells, which is not normal for the small bowel. The small bowel doesn't have the protective capabilities like the stomach does, like the mucosal barrier and the bicarbonate. So whenever you have acid-producing cells in the ileum producing acid, and then it's also getting secreted into the ileum, this is going to cause some type of ulceration. This ulceration will bleed, and this is the reason why you get a bloody bowel movement in someone with Meckel's. So the mass is most likely to be composed of cells of the stomach. All right, third question. This is kind of tricky. I didn't really go over this too much. So 35-year-old male, right-sided hernia, which is true involving hernias. Femoral hernias are the most common type of hernia in females. That is false. It's an indirect hernia. Femoral is more common in females, but it's not the most common type of hernia in females. Indirect hernias have a defect medial to the inferior epigastric arteries. That's incorrect too, because indirects are lateral. C. Direct hernias are more likely than indirect hernias to be bilateral. That is true. They are more likely to be bilateral. Let's just go over the rest of them just for completeness. Inguinal hernias that cannot be reduced, painful or not, always require emergent surgery. This is true. Wait, I'm sorry. No, this is false. They do not always require emergent surgery. They require urgent surgery. All right, sorry for the delay there. Which of the following statements regarding inguinal hernias is true? Sorry, I misspoke on this one. Inguinal hernias that cannot be reduced, painful or not, always require emergency. They don't always require emergency surgery. They often require urgent surgery, which is kind of a crappy wording. But a lot of times you can try to reduce these for quite a while under conscious sedation, which you guys really don't have to know, but just know that you don't have to have emergent surgery because of this. And then lastly, femoral hernias have low probability of becoming incarcerated. That's false. They have a high probability of becoming incarcerated just because of the anatomy. The femoral canal is very tight. Air below the left diaphragm, that's more of a sign of pneumoperitoneum, or you'll have some type of hollow viscous rupture, not necessarily small bowel infarction. Air in the biliary tree is called pneumobilia. This is most common with some type of gallstone ileus, where you have a gallbladder to small fistula. And then marked distension of loops of bowel. That could just be more an obstruction than anything, not necessarily infarction. Pneumatosis or air in the bowel wall, that's a hard sign of infarction. Next question. So again, be very particular whenever you read these stems, picking out important points of the history and physical. So the patient has severe colicky pain, vomiting, distended, no gas or stool for 2 days. So x-ray confirms small bowel obstruction, and you just think about what causes small bowel obstruction. Number one cause is adhesions. So even though it doesn't say that the patient has had surgery before or a history of hysterectomy, the question is just asking what's the most likely cause of small bowel obstruction. So gallstone ileus is not that common, even though it gets tested on. ulcerative colitis. They don't really cause strictures, so that's unlikely. Crohn's disease can cause strictures and small bowel obstruction, but the likelihood of that is very low in this patient, especially just for 48 hours. And then adenocarcinoma or small bowel tumor or large bowel tumor, kind of uncommon in a 42-year-old female. So adhesions is. All right, so this question, this question wants you to distinguish between the difference between absorption of nutrients in the jejunum and the ileum. So if you look at the answer choices here, so what is most likely reabsorbed in the ileum versus the jejunum? So the answer is bile salts. So if you think about the enterohepatic circulation, what I talked about in my gallbladder lecture, bile is reabsorbed in the terminal ileum and then sent back to the liver that way. So again, resection of 2 centimeters of any type of small bowel is not a big deal. You can take out a foot of small bowel and you won't have any malabsorptive kind of traits. So 2 centimeters is kind of clinically irrelevant, but just for completeness purposes, bile salts is reabsorbed in the ileum. So it's a 33-year-old female found to have a Meckel's, pretty proximal to the ileocecal valve. It's pretty long, 2 to 3 centimeters in length. Basically, what is the most common complication of Meckel's? So in adults, it's not necessarily bleeding or perforation. It doesn't really ulcerate, and it's not usually involved with cancer. It's usually obstruction. So it can cause like an intussusception, causing an obstruction. But the others just don't make sense. So again, this is what I talked about earlier. So you have to have a high clinical suspicion for this type of presentation. 7-year-old female, she has a tender, irreducible mass immediately below and lateral to the pubic tubercle. So it's describing the femoral canal. It's irreducible, meaning that this is an incarcerated hernia, most likely a femoral, and she's also having an obstruction from it. So the most likely common diagnosis is strangulated femoral hernia. So think about the anatomy, think about the age of the patient, and the clinical manifestations, which is a small bowel obstruction. So this is an incarcerated femoral hernia, which has to be operatively explored because these are very difficult to reduce, and the viability of the bowel is compromised. So this is a 7-year-old guy, smoker, with a right inguinal mass. It's enlarged. It's causing him discomfort. He's starting to complain of difficulty with urination and swelling, and it goes down when he rests. So this doesn't sound like an acute issue, but it's something that could be potentially fixed electively. It doesn't sound like a cyst on the cord. You would have kind of swelling down in the scrotum. Aneurysm in the femoral artery, no, you'd have a big palpable pulsating mass. A hydrocele, that would be swelling into the testicles, so that's ruled out. Nothing sounds like a strangulated indirect hernia, because if it's strangulated, it's not reducible, which this one is in this guy. So the most likely answer is A, direct hernia. Last question. In repair of a femoral hernia, the structure is most vulnerable to major injury lies. So I don't know if you guys have heard of the acronym NAVAL in regards to the anatomy of the inguinal canal. Naval, so NAVEL. So starting lateral and working your way medial, you have nerve, artery, vein, kind of an empty space, and then lymphatics, which is, in my mind, I think of the femoral canal. So if you think of a femoral hernia, which lies in the femoral canal, which is the most medial structure, any further medial to the femoral canal is the pubic tubercle. So any type of major injury that's going to occur here is going to have to occur laterally. So if you work your way backwards from the navel, it's going to be femoral, vein, and artery, and then nerve. So those are just structures that are all very in close proximity to each other in that area. And that's it for small bowel and hernias. Again, my name is Travis. I'm going to be a third-year surgery resident here at Northside. Please let me know if you have any questions regarding this topic, and I'd be glad to help you out. Thanks so much.